Hello, everyone. My name is Tyler Armstrong. Today, I'll be presenting about Alzheimer's disease, the progression and treatment of dementia. Alzheimer's disease is the most common form of dementia and is the fourth leading cause of death in adults over the age of 65. The main pathologies of Alzheimer's disease are the presence of amyloid beta plaques and tau neurofibrillary tangles accumulating in the frontal cortex region of the brain. This results in atrophy of the white matter area. These pathologies result in the clinical symptoms of dementia, which are cognitive disorders, loss of memory, loss of personality, visuospatial disorientation, and difficulty swallowing. A patient may not necessarily die because of Alzheimer's disease, but because of the complications with the disease. For example, as the disease progresses, patients have difficulty swallowing. They could improperly swallow, resulting in food being deposited in the lungs, leading to infection, or choking on food because of inability to swallow. Alzheimer's disease was originally named after the German psychiatrist Dr. Alois Alzheimer, pictured here to the far right, who in 1906 treated a patient by the name of Auguste Dieter, shown on the left. She was the first person to officially be diagnosed with Alzheimer's disease, even if it was not called so at the time of diagnosis. She was born in 1850 and started showing signs of Alzheimer's disease in her early 50s. She had trouble with her memory, could not sleep, and was having problems with language and writing. These were all signs of dementia, but she was very young to be presenting these symptoms. Dr. Alzheimer initially diagnosed her with pre-senile dementia, but was fascinated by her disease because of how young she was and the severity of her symptoms. Some days she was more herself than others, and when asked how she was on a good day, she would say, "I've lost myself," so to say. Dr. Alzheimer ordered an autopsy after her death, and her brain revealed an accumulation of plaques and tangles of fibers, as well as atrophy of the frontal cortex. These would subsequently become known as amyloid beta plaques and tau neurofibrillary tangles, which are still used as biomarkers of Alzheimer's disease today. Diagnostic techniques have greatly improved since Dr. Alzheimer's original diagnosis, now in conjunction with psychological tests to determine whether or not the patient is suffering from dementia or just mild cognitive impairment. There are also biomarker methods such as measuring the presence of amyloid beta plaques and tau fibers in the cerebrospinal fluid. Neuroimaging can also be used to determine whether or not the patient is presenting physical signs of dementia and gives insight into how far along they are. Pre-dementia or mild cognitive impairment are usually the beginning stages of Alzheimer's disease. After that, Alzheimer's disease dementia can be classified as either early, middle, or late. To the right here, we have a selection of MRI scans taken from patients with varying degrees of Alzheimer's pathology. They're overlaid with voxel-based morphometry, which is fancy speak for the computer figured out the changes in density. The higher the change in density is shown by the t-value spectrum at the bottom. As you can see, the patient at the top with mild cognitive impairment is beginning to show decreases in brain matter, and as you progress to the late stage at the bottom row, the brain has atrophied significantly. There's also neuropsychological testing that can be used when the diagnosis is unclear. They group Alzheimer's disease into four categories, ranging from unlikely Alzheimer's to definite Alzheimer's disease. In addition, Alzheimer's can roughly be categorized into four categories based on the cause of the disease, although there is significant overlap in these. There is late onset, early onset, familial, and sporadic. The cause of onset Alzheimer's disease and early onset Alzheimer's disease are not fully understood, but there's strong evidence that people with one isoform of the cholesterol packaging apolipoprotein E, abbreviated as ApoE, are more susceptible than others. You can have ApoE2, 3, or 4. People with the allele for ApoE4 represent 80% of late onset and 40 to 50% of early onset. Familial is a type of early onset that is usually associated with inheritable mutations in the gene for the amyloid beta precursor protein, abbreviated APP, as well as the presenilin genes, PSIN1 and PSIN2. Having one or more of these mutations greatly increases the chance of developing Alzheimer's disease later in life. Sporadic is not fully understood, but is thought to be a mixture of genetic polymorphisms, such as ApoE. It's been proposed that there may also be viral factors that lead to transmission of prion diseases capable of inducing Alzheimer's disease, metabolic factors that may be due to comorbidities such as diabetes. Some scientists even refer to Alzheimer's disease as type 3 diabetes. There's also environmental factors that come into play, which I will go into more details about later. The theories behind the pathogenesis of Alzheimer's disease are still under investigation and have not led to any optimal treatments that can target these mechanisms. As of right now, the only treatments available on the market are those that improve symptoms of impaired cognition without actually halting the progress of the disease. The two main theories behind Alzheimer's disease are the amyloid cascade hypothesis and the tau hypophosphorylation hypothesis. The amyloid cascade hypothesis was the first hypothesis for the pathogenesis of Alzheimer's disease and is based on the presence of the amyloid beta plaques in the brains after autopsies. In this pathway, amyloid precursor protein, APP, is cleaved from an enzyme to form transmembrane amyloid beta and can be accomplished in three different ways that result in either normal physiology or Alzheimer's disease pathology. The first is the non-amyloidogenic pathway, which produces neuroprotective elements such as C-terminal fragments embedded in the plasma membrane via the soluble ectodomain of APP alpha. The second is the amyloidogenic pathway, where APP is cleaved to CTF beta by beta secretase. This results in various lengths of amyloid beta being cleaved by gamma secretase and released into the extracellular environment. Once in the extracellular environment, they can aggregate and accumulate around neurons to cause Alzheimer's disease pathology. The third is the ATase secretase pathway. That is the alternative normal physiological outcome that does not result in the accumulation of amyloid beta plaques. Drugs have been proposed to target this pathway in an attempt to reduce the amyloid beta formation. For a while, beta amyloid converting enzyme and gamma secretase inhibitors were in style for drug developers. Unfortunately, none of the drugs to inhibit either of those targets have ever passed FDA clinical trials. This is usually due to a lack of effectiveness. Some had a plethora of adverse side effects and vital organ toxicity due to lack of specificity of the drug for neuronal targets. There are still new agents being proposed for this mechanism, some of which are currently in phase 3 clinical trials. The second hypothesis is the tau phosphorylation hypothesis. Tau is a microtubule-associated protein found in neuronal axons in the brain. Its normal physiological function is to maintain microtubule structure and function. Normally, tau is not highly phosphorylated, but under pathological conditions, it becomes hyperphosphorylated. Hyperphosphorylation causes configuration change and results in defective microtubules and elevated cytosolic levels of tau. As these defective microtubules and tau accumulate, they start to form neurofibrillary tangles. This is depicted here on the right side of the image. As these neurofibrillary tangles get deposited around neurons, they reduce the number of synapses, cause neurotoxicity, and result in overall cellular dysfunction. Like I said earlier, drugs have been designed to target this pathway in a similar way to the amyloidogenic pathway by targeting and inhibiting key kinases involved in tau aggregation or attempting to stabilize microtubules. Because the mechanism of pathogenesis are not fully understood, many proposed drugs have failed clinical trials. Although it has long been known that amyloid beta and tau are some of the main pathologies in Alzheimer's disease, there are still many other factors that are not fully understood. The causative agent of Alzheimer's disease is fairly undefined at this point. There are several known comorbidities and risk factors for Alzheimer's disease, such as diabetes, hypertension, smoking, obesity, dyslipidemia, just to name a few. Cerebrovascular disease has been shown to be one of the top risk factors for Alzheimer's disease, such as ischemic stroke. There's increasing evidence that there might be an environmental factor to the progression of Alzheimer's disease, specifically the sudden onset Alzheimer's disease, where they are lacking some of the usual genetic features, such as ApoE4. This is actually my area of research at UNT. I work in Dr. Lund's lab, where we examine the mechanistic effects of air pollution. We use cell culture and mouse models with young and aged mice as a translational approach to looking at the effects of air pollution on the progression of Alzheimer's disease. I was planning on showing some of my preliminary data to you all in class, but I do not think that it's appropriate to publish this on YouTube. But if anyone's interested in seeing that, please reach out to me. One prominent researcher in the field is Dr. Lilian Calderon Garcidunes, whose name I have just entirely butchered. She is a leading expert in the area. She's an MD and associate professor at the University of Montana. She studies the effects of air pollution on the progression of Alzheimer's disease. She has numerous publications about her autopsy analysis in Mexico City. The autopsies revealed that both children and adults had increased levels of amyloid beta plaques, signs of neurodegeneration, and neuroinflammation. If anyone gets a chance to check out my references, there are some very interesting reads in there, or just reach out to me and we can chat about it. My lab and other researchers have already linked air pollution to the disease, and some of the other known risk factors have been linked to air pollution as well, such as ischemic stroke, hypertension, and cerebrovascular disease through alterations in the blood-brain barrier. These factors fuel the hypothesis that there may definitely be an environmental component to Alzheimer's disease. All right, so now that everyone's anxiously holding their breath, let's talk about some of the drugs involved in this disease. Current FDA-approved treatments are almost exclusively comprised of cholinesterase inhibitors, such as donepezil, galantamine, and rivastigmine, as well as NMDA receptor antagonists, such as memantine. These medications do not treat the underlying disease, but may relieve some of the symptoms and slow the progression of Alzheimer's disease. There are 5 commercially available drugs that you can pick up at the pharmacy. 3-year cholinesterase inhibitors, such as donepezil, galantamine, and rivastigmine. One of them is an NMDA receptor antagonist called memantine. One combination product called Namzaric, which is a combination of donepezil and memantine. Tacrine was taken off the market in 2013. I also work in a pharmacy, and I started right around 2013, and I remember having to pull some of that drug off the shelf when it was taken off the market because of liver and kidney toxicity in a lot of patients. So many researchers have found that there is impaired synthesis and secretion of acetylcholine in the cholinergic neurons in the cerebral cortex of Alzheimer's disease patients, which results in impaired memory and cognition. Cholinesterase inhibitors are used to increase this activity through the non-competitive inhibition of acetylcholinesterase. This results in better management of the little acetylcholine secreted because it is not broken down as quickly. So there's more opportunity for the acetylcholine to bind with the postsynaptic nerve terminal. The design of these drugs is based on the mechanism of acetylcholinesterase binding to acetylcholine by targeting the serine hydroxyl group at the esteric site and a tertiary amine at the catalytic anionic site. Notice how most of these drugs have "mine" at the end of their name: galantamine, rivastigmine. Drugs in this class all possess similar tertiary amines that can interact with the catalytic site when they are in their protonated form. Unfortunately, this protonated form cannot cross the blood-brain barrier. In their neutral form, they're able to readily cross the blood-brain barrier, but most become protonated once they have crossed the blood-brain barrier in order for them to have an effect. This can result in some efficacy issues if the drug is not able to get to the central nervous system where it works. Overstimulation of the NMDA receptors by glutamate has been found to be very common in neurodegenerative diseases, such as Alzheimer's disease. The large amount of glutamate binding to NMDAR receptors opens up channels that allow for the influx of calcium into neurons. An excess amount of calcium can be cytotoxic, producing free radicals that result in neuronal damage. In this clever picture here, we have radical humans protesting something to represent these. After the channel is open, memantine blocks this to prevent further damage to neurons in the central nervous system. NMDA receptors are ligand-gated ion channels that have 4 subunits that contain NR1 and NR2 subunits. In order for the channel to function properly, the glutamate residue of the NR2 subunit and the glycine residue of the NR1 subunit must both be occupied. After the channel has been opened, the ligand binding at the NR2 and NR1, memantine can enter the channel and bind at the M2 region of NR1 and the NR2 subunits, shown right here. Because it only does so after the channel has been opened and it's binding to the enzyme substrate complex, it can be classified as an uncompetitive antagonist. As of 2019, there are 132 agents in clinical trials for Alzheimer's disease. 30 of those are in phase 1, 74 in phase 2, and 28 in phase 3. Of the 28 in phase 3, 3 are symptomatic cognitive enhancers, 8 are neuropsychiatric in nature, and 17 are disease modifying treatments. Many of the targets for these new agents have anti-amyloid and anti-tau properties that directly target the disease. Others are trials for drugs that already exist for other indications like blood pressure or cholesterol drugs, such as losartan, amlodipine, or atorvastatin, that target the underlying cerebrovascular disease that I discussed previously. If anyone has any questions, comments, or anything, just reach out to me by email and I'll be happy to discuss this with you. Thank you so much for your time. And here are my references.